Elderly patients should receive immunotherapy when indicated, also in younger patients. There should be no decision not to use it. Obviously, we know that sometimes there's a little bit more toxicity, but if you look at the benefits in terms of response rates, they are just as impressive as in younger patients. So we just need to deal with the side effects and use these treatments when indicated in elderly patients also. One of the problems with elderly patients in all clinical trials is underrepresentation. And even if there is a certain percentage of elderly patients, these are very well chosen elderly patients, what many of us call the Olympionic champions of getting old. And this is because of the inclusion-exclusion criteria in the studies. The reality today is that quite a few, not all, elderly patients will have other diseases besides the cancer. And these might or might not influence their body in the sense that the reserves when they hit a side effect might be less, so they would suffer more from the side effect. And on the other hand, the elderly patients are underrepresented because the studies either not proposed to the elderly patient or the elderly patients refuse to go into study. In many countries, they still believe that a study, what? I'm not going to be a guinea pig. So we need also to educate the elderly patients and their families or whoever is helping them to go through the cancer journey that it's not about that. It's about the fact that if you go into a study, it is most likely than not that you are going to get a very good treatment. Except, of course, you can debate about studies that randomize against no treatment versus treatment, where you can understand that people would say, I don't go into the study, I want something. We are facing today a very exciting time with these new anti-CTL4, anti-PD-1, anti-PD-L1 immunotherapies. And one of the issues we have is that should they be relatively cheap, we would say, well, as the studies show that quite a few patients benefit, maybe we can use it in almost everyone. But in some settings, it has been shown that for some drugs, you need to have a certain level of expression of one of these determinants in order to use them. But this is true for younger and older patients. This is not specific for elderly patients. The big question in the elderly patients is to identify, as for any other type of treatment, targeted treatments, standard chemotherapy, who is at risk if a complication arises, that the complication will become so difficult to control that it could jeopardize the patient's survival. And for chemotherapy, we have excellent suggestions coming in from, for example, the teams of City of Hope or of the Moffitt Center, both in the United States. But for immunotherapy, for the time being, we don't have these types of nomographs that could tell us the patient is at a high risk of complication or is not a high risk of complication. So we need to work on that. One of the discussions that I have with many colleagues is that they say, well, an elderly person probably has less immune responsiveness. This is completely wrong. We have to look at the different elderly patients. Some of them are extremely fit. They are doing just as well, if not better, than some younger patients. I'll tell you about a patient of mine who said, let's go and play tennis together. I said, no, sir, you are going to beat me. So it all depends on who the patient is. So now if we look at the studies that could help us in approaching this question, there aren't that many. There's not much going on. We need to work on that. We need to define how the immune responsiveness of the person really is, and there's very little data to show what is the correlation between some of the tests that we know show that you are immune responsive and potential response to immunotherapy, very little. And then on the other hand, some of my colleagues say, hey, but wait a second, quite a few elderly patients actually are prepped for an immune response because they do have some inflammatory disease that means that their whole body is reacting already to something, and then you put on top of that something that enhances the reaction. So it's not black, it's not white, it needs further studies. Unfortunately, today the reality is that for many reasons related to the need to register a drug, support for specific studies in the elderly, which tend to be when you address the real elderly, not those that have no problems, the super fit ones, is lacking because it is our interpretation. The companies are afraid that putting into a study a patient that has a certain number of other potential complications could relate those complications to the immune treatment rather than to the fact that the patient already had a problem, and just unfortunately this problem became a complication but is probably not related at all to the immunotherapy. So it's a complex area. However, we know that both FDA and EMA, depending on the drug, have requested post-marketing authorization studies with specific elderly populations, and these are being developed.